really been quite a few folks coming out of the woodwork who were afflicted by this during this time of COVID and the lack of access to care. And so that's why, as we've been affected by this and as people have been coping with these new diagnoses or have been sometimes isolated from care, that if it's been affecting you for longer than COVID, it's been so critical to have organizations like Cognitive Care Solutions to be able to reach out and help to find the need. And as a society, we're all trying to make the best of the situation we're faced with. Um, as sometimes access to care and you've had limits to sometimes come in to see us or to other practitioners, we've tried to keep our doors open, especially to the movement disorder population, including Parkinson's. So I'll give you a little bit of an overview. A lot of you already know, what Parkinson's is, and if anybody is relatively new to it, it's a movement disorder, which means there's some sort of abnormal coordination of movements. In this case, Parkinson's has a classic triad of symptoms of resting tremor, which usually appears not when you're holding your hands up like this, but when it's sort of resting on a table, and that's when the tremor will show up. And it tends to be slow, and they call it sort of a pill rolling tremor that can emerge, and then it tends to disappear when you're doing an action like holding your hands out, eating, etc. Like that. Usually it becomes less prominent. There's slowness, that can be slowness and stiffness of the facial features, as well as stiffness that we can feel called rigidity in the arms and legs. And it can involve difficulties with walking, oftentimes with a characteristic shuffling gait. And so it's usually good to see a neurologist, and especially a movement disorder specialist, such as our program is directed towards, in order to get the right diagnosis, because there are lookalike disorders that sometimes appear like Parkinson's. So that's sort of a brief overview. We know the disease starts most of the time, at least 2/3 to 3/4 of the time, actually, we think starts in the nerves of the gut and intestine. And there's a damage to a protein called alpha-synuclein, which, let's just say the protein looks like the shape of my hand, and it seems to get damaged into the shape of my fist. And when it gets damaged like that in those nerves of the gut, it doesn't get broken down, it doesn't have its normal activity, and it tends to stick around for a while. And it even can convert other normal versions of the protein that I sort of just demonstrated by here's the normal version of the protein, and the abnormal can sometimes serve as a template that converts it into this abnormal version of alpha-synuclein. Well, that would be all fine and well if it was only affecting the gut, and that makes a lot of sense why so many patients with Parkinson's have constipation, because it tends to start in affecting the nerves of the gut and intestinal areas. But that abnormal alpha-synuclein will travel up a nerve known as the vagus nerve that goes up through the neck and into the brainstem. And that nerve is what supplies all of the nerve innervation to the gut. But it also has connections in the brainstem up higher. Many times Parkinson's will start, oh gosh, it can start 10, 15 plus years before you ever have any symptoms. And many times when I talk to my patients, there's something in their history. There was some stressor, could be a medical injury, it could be a trauma, it could be an emotional stressor like the loss of a loved one. There's sometimes when you look back, sometimes it's 5 years, sometimes it's 7, 8, 10, 15 years ago, sometimes you can find what might have been the spark, the trigger that got this abnormal process going. And then the protein spreads, and then eventually when it arrives up in the top of the brainstem, it affects a group of nerves that produce dopamine. Those are called the substantia nigra, the black stuff. And that is where the dopamine is produced. And when it finally affects those nerves, then people really notice those characteristic symptoms of tremor, stiffness, and slowness. So that's kind of the overall, way we believe most of the cases of Parkinson's start. And there's different people who are more sensitive to it genetically sometimes, but there are only a very small group of people who have a very strong genetic risk that goes with it. Most of the cases are idiopathic and spontaneous, meaning they happen for unknown reasons to people in the population. So we can't always seem to control all of the risk factors that go with it. Now, the mainstay of treatment oftentimes, goes around replacing those deficient neurotransmitters affected by this process. And when the motor symptoms start, the main deficiency ends up being dopamine. And so when we were talking about advances in the treatments of Parkinson's, most of the time we're talking about, well, how do we replace the dopamine? And gosh, for the last 60, 70 years, we've had a medicine called Carbidopa Levodopa. Technically, it's the levodopa that's the important medication. Levodopa is produced naturally by your body, and we give you more of it, and it gets converted directly into dopamine. Well, why don't we just give you dopamine? Well, dopamine cannot get across the blood-brain barrier. We need it to get up where you need it, up in the circuits of the brain. We don't care about it out in the periphery so much. So we cleverly created a prodrug that can cross the blood-brain barrier, this levodopa. The old name for that was L-Dopa, and some of you may remember that name. And that worked great. And if you ever watch the movie Awakenings with Robert De Niro and comedian who passed away, Robin Williams, the two of them were involved, or they show the story of the discovery of L-Dopa. The problem is we used to have to sometimes use too high a dose, and it would cause side effects with people. So again, the clever scientists figured out if we mix the levodopa or L-Dopa with something else called carbidopa, it lets us use lower doses, and it helps protect it from getting broken down and converted in the blood. So that's been the mainstay of therapy, and it still is the gold standard. And really one of the other advances that probably has helped by far and away the most patients, and this is a good time of year to be warning everybody about checking to make sure that your formulary for the insurances that you sign up for, especially the HMO insurances, but any of the insurances that we arrive at open enrollment for, there's a medicine, and this is going to look backwards. It's called Rytary. So sorry, it's going to show backwards in my camera. But Rytary is a very long-acting version of Carbidopa Levodopa. And that's been sort of a huge boon to us in the last 5 to 6 years since it's been available. And if anybody were considering changing their insurance, I would, when you go on to Medicare.gov and you're checking your insurance and to see about formulary coverage, I would put that medication and maybe some of these others that we're going to talk about today into the computer to see whichever plan covers that. That tends to be a really good plan for Parkinson's people, because that has been a revolutionary long-acting version of the medicine. So it really is good at countering a lot of the motor fluctuations and on and off phenomenon. When we first start Carbidopa Levodopa, that used to be known as Cinemat, it works pretty darn well. And, people get great feelings and they don't really feel like they wear off. But, eventually there's these fluctuations in the blood level of the Carbidopa Levodopa. And that can cause the motor complications that you see in folks like Michael J. Fox, where sometimes Michael J. Fox gets kind of high doses of the medicines and he gets very dyskinetic, which I just demonstrated. Or people can wear off and they get very stiff and rigid, and all of their symptoms come back, including sometimes their tremor. Rytary, this long-acting version of Carbidopa Levodopa, really can even it out and try to keep your medicine working longer. One of the questions I commonly get asked, because there's still some old myths about Carbidopa Levodopa, is sometimes people say, oh, I don't want to use that yet. Well, it's the gold standard for the reason. It will make a difference in everybody we give it to with classic Parkinson's. And we have ways to help people absorb it better and have it work better. And Rytary and some other versions I'm going to show you do that. Then other people say, well, gee, Dr. Martinez, what about, am I going to build up a tolerance, or is the medicine going to stop working for me? Well, that was a myth that we actually, it was, actually kind of dogma that we used to think back in the 60s and 70s. But that dogma has been overturned because we find out it's not that the medicine loses effectiveness. It's just we have to give it to you in a form that can get properly absorbed by your body. So, and while Rytari is definitely one of those and probably the most powerful oral agent I have, there's even an aggressive version of a special pump. And so this is a type of feeding tube that gets used in more advanced cases. And we can deliver the medicine in a gel form directly to the intestine. And I can get every person with classic Parkinson's to respond. So it's important to realize it's not that the medicine loses its ability to help your brain. It's that we just have to be more clever about how to get it into the blood and then across the blood-brain barrier. So that's important because, boy, I would much rather you be on some version of Carbidopa Levodopa to help you, because the more help I get you, the more mobile I keep you, the more exercise you can do, and the slower the disease will be. Carbidopa levodopa in general, no matter which form, whether it's the old immediate release, whether it's this long-acting Rytari, all of them have been shown over the last, 60 years to extend your life to the average for the whole population. It decreases disability, it keeps people driving, it keeps people working, keeps people exercising, it keeps you active, it keeps people out of the hospital. There are very few medicines in all of pharmacology that can make these types of claims, and this is what it can do for this population. That's why it's so critical we find ways to make it work. So one of those ways is to try to get it to last longer. We talked about that long-acting version, but sometimes we'll give, now this is a medicine, and again, it's backwards, but it's called Ongentys. So this is a new version of a category of medicine called the COMT inhibitors. And it deactivates another enzyme that's trying to break down the levodopa out in your blood. And so you're trying to keep these blood levels even. And this has been a really useful medicine in the last year or two since it came to market. And it's helped to sometimes maintain people's on time. So again, you don't have as many of these fluctuations. In my ideal world, I try to, by hook or by crook, I try to find ways to get the medicines to keep your regimen as simple as possible, that I try to keep it to 3 to 4 times a day that you're having to dose some version of Carbidopa Levodopa. Now, and these medicines keep you from having to go to 5 times a day or 6 times a day or more complicated than that, because sometimes the medicines, again, have a hard time getting absorbed or the body's breaking them down too quickly. So that's one option that we have. Another clever option that we oftentimes will use different routes of administration. I mentioned the pump called Duopa, but there's another way that's been sort of a very clever device to try to get that medicine on quickly. Because when people go off and they become very immobile and you kind of feel like a statue, that can be very uncomfortable for people. And of course, you can lead to significant immobility. So one of the things I wanted to show you was a way to break some of that, that sudden off period where the dopamine levels dropped. And so there is a device, and this one is called Imbresia, and this is an inhaled device. So this gives you a short burst of just the levodopa, and you can breathe it in and it'll get absorbed through the lungs. And so this is great if we need to get quick relief and get you back on and get you back mobile when you're stuck. And so these, this little inhaled device, you put your mouth onto this and you you take short breaths in, because it's a powder and the powder is going in and it gets absorbed effectively by the lungs. Sometimes you cough a little bit, but boy, I've had some people that this has really been able to rescue them quickly, and it gives you just a short dose that'll get you mobile for like an hour or so. It's not going to last much longer than that because it's going to get into the blood quickly, and it doesn't get delayed by a pill has to go from your stomach to the intestine and then finally get absorbed and then go through the liver and then finally get up to the brain. And that can take a while. Some people's pills can take 30, 60 minutes or more to kick in, but these inhaled versions can kick in much quicker. So, sometimes we choose a different form to get it to work better for you. So great rescue treatment that we have when things get frustrating for our patients. So that's definitely something you can talk to your movement disorder specialist about. Okay, so that's really, some of the big areas focusing around dopamine to target. We do have other agents that can sometimes break an off period. Sometimes we don't use levodopa or dopamine. We use something that looks like dopamine called a dopamine agonist. And there's been sort of an agent that, we've got these, they're little sublingual versions of apomorphine that have been very useful sometimes to also break people's off times. Now, apomorphine, that sounds like morphine, but it's not morphine. It is not an opiate at all. It is just a medicine that looks like dopamine, and it kicks in quickly and lasts for about an hour to 2 hours. And we have it available in these sublingual forms, and there's an injectable form. So there's kind of these two different versions that have been available. These are all great for people who, if you meet these criteria, like if you start really off in the morning and boy, you're just stuck, as soon as you wake up, you're just really, really immobile, that's a good way to get things started in the morning if the pills just aren't kicking in quick enough. Another group of people that we would think about some of these approaches would be if you do have sudden, unexplained, erratic off times, or people who have a lot of constipation that can't absorb their meds real well. These alternative routes, either sublingually or injection wise, or these inhaled versions of types of medicines that stimulate dopamine, these are all ways of trying to get you up and moving and functional in as short a period of time as possible. Try not to wait an hour or two, trying to get you better within minutes. Okay, so these are great rescue approaches that can help with people. And sometimes, some people might use them once a month. Some people might use them once a week. I have a lot of people who sometimes, hey, they need to use them, 1, 2, 3 times a day because when they go off, and we just haven't been able to find another regimen to really keep them on. Okay, so those are all good dopamine approaches. But oftentimes people will tell me they're having, other types of symptoms other than just motor symptoms. Sometimes people will complain about non-motor symptoms with Parkinson's. Now, this is oftentimes involving other neurotransmitters. Gosh, it's a whole lecture in and of itself, but non-motor symptoms can involve anything from anxiety, depression, attention problems, constipation, blood pressure fluctuations, especially low blood pressure, especially when you stand up. These are all just a handful of examples of that. It can be erectile dysfunction. It can be, either increased sweating or decreased sweating. Changes in a lot of this autonomic nervous system function. It can be really important to help the body. Well, it's obviously very critical that the body regulates this, but the Parkinson's group, they tend to lose the ability to regulate this themselves. And some people, I need to help them regulate it. Obviously, this isn't for everyone. This is really the customizable part of kind of the art of treating Parkinson's. So sometimes we have, one of the most common, and 80 to 90% of all Parkinson's patients will have some degree of constipation. And so constipation and treating it with over-the-counter treatments, things like prunes, dietary changes, chia seeds, those types of things can all really help with constipation. But if you're really struggling and the over-the-counters like Miralax and Colace and Ducalax and magnesium are just, and prunes just aren't cutting it, we've had really good luck with a prescription medicine called Linzess. That's been really critical. And why why is it important to keep the gut moving other than just, comfort, right? Keeping the gut moving keeps the medicines moving, and the medicines need to move through the gut to get absorbed appropriately. And so, I remember going in neurology thinking, I never need to do anything GI. I don't need to learn how to treat constipation. Well, then I met all of you with Parkinson's and I realized, no, 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 I need to become the master of constipation because it's so uncomfortable and it's the most preventable and avoidable ER visit and hospitalization. And it's not just a comfort issue, although we all worry about that, about our own, bowel function. It really is critical for keeping the medicines working. And this is what prior generations of folks with Parkinson's and the neurologists who treated them didn't realize, and we didn't have those tools. Additionally, people underestimate the fact that constipation can also cause blood pressure to drop, and it can even cause some cognitive slowing and memory problems because the bacteria that overgrows during constipation can cause levels of ammonia to rise in the blood, for instance, and that can lead to some treatable, avoidable confusion. So these are all the little subtleties, but that's what I get to talk to you guys about because you're kind of asking me, well, what have I learned after all these decades now of treating Parkinson's? Because I'm into my third decade of this. And so a lot of this is based on, pulling a lot of information from my mentors. And then a lot of it has been based on the last 20 years where I've done intensive working with all of you and sometimes some good observations from your standpoint. We talked about drops in the blood pressure, critical for treating because, and this is important to cognitive care solutions, they want you thinking as sharply as you can be, and they're doing all the exercises with you. But it has been shown in Parkinson's patients that, their IQs tend to stay good, but they have a slowing of the processing of their thinking. But one of the other things that's been underestimated is many times people will have a drop in their cognition when they're standing up versus when they're sitting down, when their blood pressure drops. So that's interesting. They gave people cognitive testing, like what Cognitive Care Solutions does for folks, and they tested them while they're doing it sitting, and then they had to do the same test at a standing desk, and the people didn't perform as well when they were standing, when their blood pressure was dropping. So Parkinson's people have the opposite problem of all the rest of us, right? We're all worried about high blood pressure. I can almost guarantee you in 80+% of all Parkinson's patients, if you had high blood pressure before you had Parkinson's, your doctor should always be watching to see when you need less high blood pressure medicine, because eventually your blood pressure is going to drop. So you need less of that. Your high blood pressure may actually disappear when you have Parkinson's. And that's one of my favorite things to do is pull away high blood pressure medications, simplify your regimen, and you feel better because you feel less dizzy and suddenly you think a little more clearly. But sometimes I even have to go the opposite direction, right? I pull all your high blood pressure medicines away and your blood pressure's still dropping. And Cognitive Care Solutions is telling me, hey, they're still having problems. They're feeling fuzzy and they're thinking. And I say, well, I might need to use a medicine to raise your blood pressure. There are good medicines that do that. There's something called midodrine. There's another one called fludrocortisone. And this one's pretty expensive, but it's called Northera. And it replaces another neurotransmitter that's deficient in Parkinson's people called norepinephrine. And so it replaces kind of the brain and some of the nervous system's version of adrenaline, which you guys have all heard of adrenaline. And so that's epinephrine. So this is the nerves and the brain's version of that called norepinephrine. And it can help to raise the blood pressure and keep it from dropping. And suddenly it can improve, your thinking and cognition, and you don't feel as dizzy, and it's oftentimes that vague dizziness that they just don't feel right. And many times that can be blood pressure. Now, your primary doctor, your neurologist, or your cardiologist can check that, right? All they have to do is check your blood pressure when you're sitting and then when you're standing. And if your blood pressure drops significantly, or your pulse starts increasing by about 20 points or more every time you stand up, those are all indications that you're you're losing the ability to regulate your blood pressure, and maybe you need a little help if you're feeling symptomatic. Now, obviously, I don't always have to treat this. I don't treat the numbers, I treat the person. If you're not symptomatic, I may be more hesitant about using medication. But if you are starting to have some symptoms, or I think it's starting to appear, that's a good reason to treat it. Okay. So let's then, I'm going to transition to a slightly different group of medicines. Oddly enough, I'm actually going to talk about one of the oldest medicines approved in Parkinson's. And this is a medicine that some of you may know of, and it'll surprise you. And it's a medicine that I've regained a certain amount of respect for it. And it's sort of like what's old is new again. But it's been a fairly powerful agent in some tricky situations. Now, this is more of a niche medication. I don't give this to every Parkinson's patient, but some of you may know of an old antiviral medicine known as amantadine. Amantadine was invented to fight against influenza, like true flu. And it has some anti-influenza properties, it does. But amantadine is an interesting medicine. Historically, it can work for tremor in Parkinson's. It can work for dyskinesia, like Michael J. Fox has, and it can calm that. And it can rarely, maybe about 10% of people sometimes notice a little bit of energy or countering of fatigue. And so it's a pretty interesting little medication. And I've always kind of known those three uses, and I've used it historically, but now they've come out with some long-acting versions. This one happens to be something called Osmolex, and it has a cousin called GoCovery. So GoCovery. So these are all just long-acting versions of amantadine. And when they came out initially, I was like, oh, okay, that's nice. It's once a day. Okay. But I will tell you that they have changed my opinion about amantadine. And there's a fourth thing that amantadine can help with. I've seen it help with gait and falling problems in my Parkinson's patients, and it has been a very pleasant surprise. So, and they have been able to achieve that where the immediate release generic has not. And that's been very gratifying for some of the later stage Parkinson's patients that I take care of, to have something that not only is better tolerated and simpler to take, which is once a day, but that bathing of the brain evenly with the medication has clearly now enabled us to see another positive effect from it. So that's where, the old dog is learning new tricks here. And my patients have helped me gain insight to that, even though that's not what the company studied it as, but that's what we have seen it work for when it has come out to market. Sometimes gait problems can respond to unusual medications. So one of those is a memory medication. It's a mood medicine called Trintellix. So Trintellix is a medicine kind of like, it's similar to medicines in the Prozac, Lexapro, Zoloft, Paxil family. But Trintellix has also helped with Parkinson's gait problems, which has been also useful in a problem that can be very frustrating. Trintellix also has been shown to help in people with anxiety, depression symptoms, and it's been helpful in memory in those. That's kind of what it's approved for, is for anxiety and depression, and it does help some of the subtleties that come with memory. Okay, let's see. Again, sometimes other motor complications of Parkinson's, and oftentimes earlier in the disease, there's a medicine that's hit the market this year called Nurians. It's been a relatively easy medicine to add in, and it works on an entirely different neurotransmitter called adenosine. So your movement disorder doctor might use that if you're having sort of, freezing spells or off phenomenon, and it can sometimes even out your motor symptoms. It's one of those subtle medications. And so we continue to, we're still relatively new. We're sort of still sprinkling amongst a number of patients to I haven't quite figured out what the perfect candidate is for that one, but I wanted you all to know about it It's one we definitely had to be a little more patient with, usually closer to like 8 to 12 weeks. We have to wait to really see some improvement. So I just wanted to relay that to all of you because you'll maybe read about it out there. Okay, now I think I have one last medicine I wanted to bring up, and this is for, again, kind of middle to later stages in Parkinson's. Sometimes, we're trying to give you dopamine to help your motor circuits, which are deep in the brain. And those are deficient, and it definitely helps you. And those are all of the Carbidopa Levodopa medicines and all the dopamine replacement medications. But as we age and as the Parkinson's advances, sometimes our frontal lobes, our thinking areas, can start to encounter, um, something called psychosis. Psychosis is defined in Parkinson's as sort of either delusions. So you have kind of a fixed false belief. Maybe paranoia is an example of a delusion that you think people are out to get you. It can also present as a visual or auditory hallucination. Sometimes it may present as a tactile hallucination where you feel somebody touch you on the shoulder, but that's not there. It didn't actually happen. So those are examples of psychosis. And oftentimes in Parkinson's, it can be somewhat benign, like you'll see children running through the room, or you might see an animal like a monkey in the tree, but there's no monkey in the tree. It was just maybe the leaves or the branches moving in the wind. These are all examples of hallucinations. That's indicating just that your frontal lobes are not tolerating the Parkinson's. Sometimes we can help that by adjusting the Parkinson's medications and the dopamine medicines, but sometimes we need to help you with a medicine that blocks this psychosis. If it's real mild and early, and especially if there's a significant other giving some insight to people and telling them, oh no, that's not real, that's good. But if it's starting to get into paranoia, or the hallucinations are getting either frightening or annoying to the patients, that's when we sometimes need to use the medicines that block psychosis. And sort of by far and away, the cleanest medicine is this is a P, Nuplazid. That medication has really revolutionized our ability to be proactive and be able to block a lot of these symptoms of psychosis. Psychosis can even present as a magnification of anxiety, sometimes, a lot of other physical symptoms and sort of this internal tremor that affects people. All of those can be there, where I can't see the tremor, but the person feels it inside. These are all examples of things that Nuplazid has been able to help my patients with in a gentle way, but a very effective way. So all of these are things that I just want you all to be at least aware of. These will not affect everybody with Parkinson's. A lot of these non-motor symptoms, might only affect 5 or 10 or 20% of people with Parkinson's. So don't listen to what I said today and just think, oh, I'm going to get all of that. No. And of course, your neurologist is only going to treat it if it appears, right? There's no reason to take any of these pills for non-motor symptoms until the symptoms actually appear. And if they do, great, then your neurologist should treat it. Okay, so that was a lot of the new issues that I wanted to talk about. I guess I should at least say one more thing. I should also always tell you about the ongoing advances of deep brain stimulation. And so deep brain stimulation, this is an example of 2 particular manufacturers and their devices that help, which are pacemakers for the brain. So there's a pacemaker that would get implanted, and nowadays we usually do 1 pacemaker, and it runs 2 wires deep into the brain that helps. And this will help with not in like the first year, but in folks who have refractory tremor, in folks who are really having probably significant on and off motor complications. The medicines are getting more complicated. We're having to be, I'm really having to pull out a bunch of different tricks to try to get you better quality of life. Or maybe you're starting to get sensitive to some of the side effects of these medications, including some of those psychosis symptoms. Deep brain stimulation is really good at not only making, close to a 50% improvement in your activities of daily living and quality of life, which is the most important to all of you, you can get about 50% better than how you're doing on best medical therapy. Meaning, if I use every trick I've got in my book, I can still get you about 50% better with deep brain stimulation. And it's the only thing I can do that allows me to decrease your Parkinson's medications. On average, anywhere between about 30, sometimes up to about 50%. Usually in my office, it's a little closer to 50% that we're usually able to come down on it. And we've got data going out well beyond 20 years that shows us not only does it work and you continue to be better than people who are on best medical therapy, but you continue to be on much less medication than people on best medical therapy. And that's an important long-term piece of data that I didn't have 20 years ago that I now have to tell all of you.